Path Medicine, a guide for the medical student who likes to ask why. Now that we've understood the underlying pathophysiology behind postoperative ileus, let's now discuss how this mechanism leads to understanding the risk factors for developing postoperative ileus. So we'll classify it in the same way, talking about inflammation, neurology, and pharmacological agents. So let's talk about inflammation. So the first category under inflammation is tissue damage, because as we discussed before, if you damage tissue, so you damage cells of the bowel, it's going to cause the release of those damage associated molecular patterns, DAMPs, and that's going to cause a cascade of events leading to inflammation. So naturally, having repeated surgeries means you get more episode of tissue damage, so you're going to have more inflammation. Having an open surgery means you're going to get more damage to cells because you're cutting more tissue, and as a result, you'll get more inflammation. Having a wound that's larger again indicates more tissue damage, and again, is going to promote inflammation. And finally, the degree of bleeding has two aspects to it. Number one, that if you have more bleeding in the operation, it generally indicates you have more tissue damage. And number two, bleeding itself can stimulate the sympathetic nervous system. And the sympathetic nervous system, like we said, is going to be a risk factor for developing postoperative ileus because it inhibits smooth muscle contraction. Finally, other categories we can talk about are peritoneal irritation. So if you irritate the peritoneum, you're going to irritate the mast cells which reside in the peritoneum, and so you're going to get more of a release of these cytokines and chemicals like histamine, which is going to cause the development of postoperative ileus. And finally, tissue handling. Naturally, if you have a longer operation time, you're going to have more handling of the tissue. And just remember that the bowel has never been handled by surgeons before in most patients, so the body's going to treat that as foreign, and therefore it's going to release those damage associated molecular patterns, leading to the cascade of events causing inflammation, which will then in turn lead to the development of postoperative ileus. Now let's look at the underlying neurology. Now, I've already looked at this, but we're going to focus on a couple key agents and factors that we've not discussed before. The first is thoracic epidural agents. Now, these agents are protective factors for developing postoperative ileus. They can help prevent you from developing postoperative ileus. And that's because the sympathetic nerve fibers exit at the thoracic spinal cord. So if you give the anesthetics, which causes impairments of neuronal transmission in these nerve fibers, you therefore have an inhibitory effect on the sympathetic nervous system. So you don't get the sympathetic nervous system causing inhibitory signals which impair smooth muscle contraction, which means the parasympathetic nervous system is going to start to outweigh the sympathetic nervous system, and so you'll get smooth contraction, and that helps protect against postoperative ileus. Other agents we're going to talk about is anticholinergics. And anticholinergics, their cholinergic refers to the parasympathetic nervous system. Anti means against, so they inhibit the parasympathetic nervous system, so you don't have its stimulatory effect of the enteric nervous system to cause smooth muscle contraction. And finally, electrolyte abnormalities. Electrolyte abnormalities like hypokalemia or hyponatremia can impair the signals from the enteric nervous system, so the nervous system of the bowel, to the smooth muscle cells to stimulate contraction. So if you have an impairment over here, it can lead to the development of postoperative ileus. Now that we understand how this condition works and what factors can lead you to develop postoperative ileus, let's talk about how we clinically diagnose postoperative ileus. And we'll split this into looking at factors in the history, looking at factors on examination, and looking at factors in terms of investigations that we can order. Now, in terms of constructing a differential, the main condition you need to rule out is postoperative small bowel obstruction, because, like we talked in the definition, postoperative ileus is in the absence of any mechanical obstruction. So, in terms of the diagnosis, we're going to really focus on how we distinguish postoperative ileus from early postoperative small bowel obstruction, because the other conditions it can present at tend to be more obvious, and this is where the key differential and distinction you need to make is. So first of all, let's talk about the nature and severity of symptoms. Postoperative ileus develops slowly. It has a very insidious onset, meaning that it's very difficult to initially perceive the symptoms and it will kind of creep up on you. Whereas postoperative small bowel obstruction, in contrast, is acute and it's severe. You've got a physical obstructing point, like we talked about here, where you get a sudden build-up of pressure. So that means you're going to get pain very quickly and it's going to be more severe. On examination, features that you want to look out for is peritonitis. So peritonitis is inflammation of that peritoneum. Now the peritoneum has somatic innervation, so you'll feel it as a very localized pain. And if you get generalized peritonitis, you can get features such as guarding and other features such as rigidity, which are markers of generalized peritonitis. In postoperative ileus, you have no obstruction, so you generally get no peritonitis. In early postoperative small bowel obstruction, you may get features of generalized peritonitis purely because if you have a buildup of pressure, that pressure can start to compress blood vessels within the bowel wall. That causes tissue damage, and that tissue damage can cause a break in the wall. And so you can get, if you look in this diagram here, a leak of the contents of the bowel, and these contents can start to cause irritation of the peritoneum, which is extremely painful. The patient won't be able to move. Coughing will cause pain. If you tap on that area, you'll get tenderness, and you tend to get this rigidity as all and guarding as all your muscles tense up. Other features is obstipation. So obstipation is the complete lack of passage of feces, but also passage of flatus, and that will never happen in postoperative ileus because whilst the bowel transit time is increased, it is still being able to propel feces. There is some propulsion and there's no physical obstructing point, so you should be able to pass wind and be able to pass stool. So this is all about passing wind plus stool. So if you can't pass both, we call it obstipation. And finally, an auscultation. If you have early postoperative small bowel obstruction, you'll get this tinkling high-pitched sound as all the feces, the small liquid feces, is trying to force its way through a small hole. Whereas with postoperative ileus, you'll generally get uncoordinated bowel sounds, reflecting the fact that you've got uncoordinated bowel contractions. Now let's finally talk about investigations that we can order. So clinically, we're suspecting that this could be postoperative ileus, but we want to rule out if it could be a small bowel obstruction. So what we can do an abdominal x-ray, and the abdominal x-ray will show a clear obstructing point for postoperative small bowel obstruction. It can show a clear obstructing point. And whereas postoperative ileus, it will generally show some distension and some air fluid levels, and that's just reflecting that the fact that there's no impeding point, and it's a general just impairment of bowel contraction and backflow within the system. The final test, if we're still not unsure, for example, the abdominal x-ray isn't really showing a clear obstructing point, but it's quite an acute and severe presentation, so we're thinking it could be small bowel obstruction. And that's where we can use gastrogafin. So gastrogafin is a contrast agent, and effectively, if we look at the diagram here, over here, if we say that this green little blob here is the gastrogafin, and this blue is the proximal bowel, and this is the distal bowel, and this dotted line here is the obstructing point. When you give the gastrogafin contrast agent and wait for a few hours and do another scan, you expect to see the gastrogafin agent throughout the bowel. However, if you only see the agent in the proximal bowel and the distal bowel isn't lighting up, it means you've got a clear obstructing point. So if the gastrogafin is not present in the large bowel, it points towards a diagnosis of postoperative small bowel obstruction. The small bowel is obstructed, gastrogafin can't get into the large bowel, so you don't get that area lighting up. Now, a lot of you may be thinking on the wards or have heard of other agents that we can use in tests, and one of them is barium, which we typically use if patients have difficulty swallowing, for example. But the reason we use gastrogafin is because of three reasons. So first of all, gastrogafin itself, it has a very high oncotic pressure, so it causes a lot of water to go into the bowel because it has that tonicity effect. It forces water to go into the bowel because it has a very high osmolality, forcing water into the bowel. And because you have more water into the lumen of the bowel, it causes more stretch on the bladder wall, indicated by the orange arrow here. And when you get stretch of bowel wall, it triggers it to contract. And that contraction and the fact that you're causing that stretch helps to prevent adhesions, which are one of the main causes of small bowel obstruction. So we like to give it because it's also therapeutic. Secondly, gastrografin itself is less irritant than barium. So like we talked about post-anastomotic leak, or in the case of peritonitis, we get a leakage of contents. Gastrografin itself, if it does extravasate, so leak from the bowel, it's not as irritant as compared to barium, so it causes less symptoms for the patient, which is one of the reasons we prefer to use it. And finally, it has a very quick retention time. Gastrografin doesn't stay in the bowel for long, so if you need to do further scans, it's not going to interfere with those scans like barium would, because barium stays in the bowel for longer. So those are the three reasons why we prefer gastrografin to barium. Now for the final part of this video, we'll talk about how we can manage postoperative ileus. And we'll split this in things that we could do to prevent postoperative ileus and things that we can do to cause a control of the symptoms of postoperative ileus. Now, in terms of preventing the symptoms of postoperative ileus, it's really what we're doing is we're working at those risk factors. So, in terms of pharmacological agents, we want what we call a balanced analgesia approach. We want to use agents like non-steroidal anti-inflammatory drugs or things like paracetamol, because that will reduce the pain a patient's feeling, and so it will cause less of a reliance on opiates, which we know are implicated in the pathogenesis of postoperative ileus. Other things that we can do is that we can avoid hypervolemia. So, whilst it's important to make sure patients have optimum fluid balance, we don't want to be overzealous in the fluid that we can give patients because it can promote gut wall edema, which we explained can cause the development of postoperative ileus. Finally, in terms of another factor related to interventions that we can do, we can help patients in terms of getting them to feed early, because if they feed early, it causes mechanisms such as the stimulation of the gastrocolic reflex. The gastrocolic reflex is the idea that when you have food in the stomach, it sends signals to the bowel to cause contraction of the bowel. The idea is to start moving the feces further down the bowel so you have more room for the food that's coming in. And that reflex itself, if you can start to stimulate it, it helps to promote contractions and helps to prevent postoperative ileus. Another factor is related to gum chewing. So, gum chewing itself can increase vagal stimulation, which is increasing parasympathetic stimulation, which again promotes contraction. The final preventative factor is that we generally like to do minimally invasive surgeries, such as laparoscopic and robotic surgeries, and some academics are even saying that robotic surgery can further reduce the risk of developing ileus for generally minimally invasive surgeries. But you can't do that for all patients because we have to judge the operation, and sometimes they may need an open operation, but where we can, we like to do minimally invasive surgeries. Now, there are factors that are debated within the literature. So they're not part of the guidelines, but it is generally good to do. So one of them is early ambulation. So early ambulation, some studies debate whether or not it actually reduces the risk of ileus, but generally it's a good thing to do for surgical patients because it helps shorten their hospital stay, reduce the risk of developing DVTs. So generally, early ambulation is a good thing to do, but in terms of directly causing postoperative ileus and helping to prevent it, it's debated. Now, in terms of symptom control, two other debated points are the use of prokinetics and non-steroidal anti-inflammatory drugs. Within the guidelines, the first-line agent is not to go for prokinetics, but based on the clinician's view, the idea is prokinetics stimulate bowel contraction, and that should help ease the symptoms of ileus. So it is an option, but it's not the first-line agent within the guidelines. Other things is non-steroidal anti-inflammatory drugs, whilst they're helpful for using as a balanced analgesia approach, Using them for the purpose of reducing inflammation hasn't been shown to be as effective in reducing the incidence of post-operative ileus, so that is debated within the literature, and you have to be aware that they can cause renal impairment, so they can't be used for all patients. But factors that are related in the guidelines in terms of treating the symptoms of postoperative ileus are correcting electrolytes by giving adequate fluids, because that reduces an underlying risk factor. And if, especially if patients have the prolonged postoperative ileus, having an NG tube can be helpful. But again, this isn't first line, this is for patients who have developed prolonged postoperative ileus. But generally, the guidelines focus on prevention as the key, because we don't want patients to have the symptoms of postoperative ileus. So let's do a quick recap. We've talked about how we define postoperative ileus based on as a concept and clinically on these clinical factors. We talked about how we can classify it based on the duration and the underlying cause, and the underlying cause into primary and secondary, where the key thing is to remember first fluid and follow this flow chart. Then we talked about the underlying mechanisms and how we split them into inflammatory, neurological, and pharmacological, and how they feed into the risk factors for developing postoperative ileus. So if you want to know the risk factors, learn the underlying mechanisms and tie the two together. We talked about how we can diagnose it, and particularly how we can distinguish postoperative ileus from history, examination, and investigations from small bowel obstruction. And finally, we talked about management, the most important being prevention. For a comprehensive guide of all the information covered in this video and more, please be sure to check our blog at navmedicine.wordpress.com. Thank you.